You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 22nd, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, aspirin-exacerbated respiratory disease. Our presenter is Dr. Rodney Johnson. He's an allergy immunology fellow at Children's Mercy Hospitals and Clinics.
Okay, we're going to go ahead and get started then. Welcome to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City. Today is April 22nd, 2011. We're going to talk about a patient management issue today, and our person who's going to lead this discussion is Dr. Rodney Johnson, who's one of our second-year allergy immunology fellows here at Children's Mercy Hospital. So without any further delay, I'll go ahead and turn the podium over to Dr. Johnson, who will talk with us about an interesting patient. Let me just pull up your powers. There you go. So take it away, Dr. Johnson.
Okay. All right. So, management conference. So here's the clinical case. Got a 37-year-old female presents with a chief complaint of, quote, nasal congestion. She is sent to us by ENT to, quote, start allergen immunotherapy. So her nasal congestion symptoms started about 5 to 6 years ago, and so she has the congestion with the runny nose, or started that way, and also decreased sense of smell, but doesn't really have much itching involved, maybe some mild sneezing, but no real post-nasal drip. Symptoms. She tried several antihistamines, but it didn't really seem to help. Symptoms are year-round, and she's been blood tested 2 years prior, but was all negative except for mildly positive to cat. When I say negative, I mean less than 0.35, but there were several what was, quote, positive from LabCorp, because they consider anything from 0.05 is positive.
So this was a LabCorp.
They were at the LabCorp, so it's, I think it's radio immunoassay, the actual RAST, I think, with them. So
as opposed to immunocap.
Correct. So further history, she actually noticed that about a year after her nasal symptoms began, she started having problems with some dry cough, wheezing, shortness of breath, and chest tightness. So she was diagnosed with asthma around that time and started on asthma medications. And then she noticed that progressively her asthma symptoms and her decreased sense of smell and nasal congestion that seemed to get worse over the years. And actually she was she works at a dentist's office and was there, and all of a sudden had an acute asthma attack. It was pretty severe. She almost died. She was intubated. She had seizures from hypoxia. It was pretty severe. And she thought that it may have been triggered by maybe she was chemicals she was exposed to at work, but not real sure. But she also notes that her asthma, whenever she's in the red zone, that her nasal symptoms are significantly improved as well when she takes the prednisone. So what she thinks her triggers, if she's under stress and if she has any type of NSAIDs, and specifically has had reactions to all three of those, aspirin, ibuprofen, and Aleve. And within a few minutes, she'll have an immediate asthma attack. But prior to maybe 5 or 6 years ago, she was able to take all those medications and never had a problem. But she does say Tylenol is fine. And although she uses albuterol every day, she feels, and even though she almost died from an asthma attack, she feels that her nasal congestion is actually more troubling than her asthma, because she absolutely can't breathe at all through her nose. So some other past medical history, the chronic nasal congestion. She's had 2 surgeries for nasal polyps, and she had asthma in her father and her daughter, and her father died from an asthma attack, and she believes that her maternal grandmother also died from an asthma attack. Doesn't smoke cigarettes, but occasional marijuana, occasional alcohol, and there's no pets. So allergies, other than what those previous NSAIDs that worsen her asthma, no other drug allergies. But she's on Allegra, Rhinocort, Singulair, some dexamethasone nose drops, Symbicort, albuterol, prednisone in the red zone. The most recent was 1 month prior, but she's only had 2 courses in the last year.
What's the dexamethasone nose drop?
That's ENT uses that a lot for nasal polyps to keep them from growing too quickly.
What's the Rhinocort?
I think it's whatever the highest, like 2 sprays a day or something, 2 sprays in hospital a day or something.
So they think the dexamethasone and the Rhinocort together is more effective than either one?
I don't know.
I just see them on the dexamethasone.
Really?
You don't usually put them on the intranasal steroid too.
Yeah,
I would say the polyps.
Usually the highest, usually you're given like Rhinocort, for an adult, you'd be given like at least 2 sprays each now, so twice a day sort of thing.
that's what
to try to prevent them from recurring. But have you seen the dexamethasone used to?
They do that pretty much all of the.
Is that supposed to be much stronger than the Rhinocort, or?
At least they think so.
They put everybody on it. Their polyps.
You end up with a systemic effect too, and we know that systemic steroids work pretty good. So that's when you get prednisone.
Yeah.
I guess from an allergist perspective, diagnosis is probably becoming pretty clear. Maybe not be quite so difficult.
Where's Dr. Wall when you need him? Jake? Where's Dr. Wall when you need
Very well. Oh yeah, I remember.
So physical exam, the vitals are fine when we see her in clinic. Her nose, nasal passageway is basically completely occluded because of large nasal polyps. But her lungs are clear. As far as labs, she's had the previous CBC about a year or 2 earlier. A couple of them had absolute eosinophil counts 1.23 to 1.48, and high normal is just for reference is 0.07. She also had she's had a few CTs, but the most recent one I couldn't get it to get a picture, but it was pretty impressive. But complete classification of basically the sinuses, and she had polyps. The day of that she was there, I got some PFTs. Essentially, you can see she's got some mild obstruction today with this 65 ratio and 92% predicted FEV1, and DLCO was fine, so it was consistent with obstruction/asthma. So differential diagnosis is essentially kind of becomes smaller after this classic presentation. But we were obviously thinking that aspirin-exacerbated respiratory disease, so we were thinking that probably this single capped IgE of 1.1 is probably not the main culprit of her symptoms, and therefore, we'll eventually skin test her, but she was actually taking antihistamines that day, but the AERD was the most likely culprit of what's going on. So, plan for aspirin desensitization after about a month from her sinus surgery. So, talk to the ENT. They're going to do surgery anyway for the 3rd time. So, a month after that, we saw her in clinic 1 week prior to explain the procedure, get consented, and make sure her PFTs are okay. And this is per practice parameter from 2007 in Annals on AERD, aspirin desensitization. Making sure she's taking her Singulair and Symbicort and kind of stressed the importance of not missing any dose, and told her to hold the antihistamines for 48 hours prior to the desensitization. So what we did, and this was this past Tuesday and Wednesday. So one of the things is where to do it. In the past, it's sometimes you would admit or even to the admit them to the intensive care unit, but there's actually there's practice papers about outpatient use or outpatient clinic desensitization. But the outpatient clinic that's the allergy or pulmonary clinic is not exactly the same as an allergist in the communities area, because they have a bronchoscopy suite. Therefore, they have advanced cardiac care support. They have, the vent is right there. They have telemetry, continuous pulse ox. So essentially, you have the same amount of information that you would get if someone was in the ICU. So we decided to do it there rather than admit to the floor, one, because actually I think you have better supervision and close observation than on the floor, and you had to send to the ICU. Well, you got to convince a critical care attending to admit over 2 days, or admit and then discharge, and given the severity of most of their patients, that might be difficult to do, in addition to it being extremely expensive. So we placed an IV, put her on continuous pulse ox, and we made sure that we already had the albuterol, racemic epi, jet-nebs available, epi, IM 1 to 1,000, and then the Benadryl, of course. And we obtained the PFTs. So before we started, so at 8 o'clock or 8:15, FEV1 is 2.97, which is roughly 100% of predicted for her, almost. Vitals are good, so we give her a half a baby aspirin. And then roughly 90 minutes later, we check the FEV1 again. The vitals are good. Everything's looking good. So instead of waiting 3 hours, since very few people reacted to the half a baby aspirin, we just used 2 hours later. So we went ahead and gave the 81. And she started noticing about an hour later that she felt like she had a lump in her throat, and she said it was mild. And although it had no coughing or wheezing, she said it felt like a mild initial asthma flare. So her FEV1 is it's only about 6.5% lower, but her lungs were clear. So checked her on her again. Subjective symptoms have mildly improved, and but there's no objective symptoms. So after 3 hours, everything's looking good. Repeat the FEV1 is fine. Vitals look good, so we went ahead and gave her the 162. And then 90 minutes later, check the FEV1, looks good. And finally, 3 hours later, everything looks well, so we discharged her from clinic that day. So day one's looking good. Day two, brought her back in. The same pre-challenge procedures were the same. Check the baseline spirometry. Once again, FEV1, doing well. Give her the dose of the 325. Wait 90 minutes. Once again, everything's looking good. And then finally, 3 hours later, everything's looking good. I didn't put the vitals up here, but they were fine, of course. So she went through the whole thing without requiring any treatment. So we discharged her, told her to take 325 at home that night, and then 650 the next morning, and continue twice a day. But she can take that at home and doesn't have to call or doesn't have to come in. But and then follow up in 6 weeks. So that was basically the whole protocol that we did. And, hasn't called back, and so far it's going to be on 650 BID for now. So, sure.
It seems kind of scary. They're giving the highest dosage.
Yeah, I know. That's what I thought, because I'm thinking that when I'm thinking about that dose, we're always thinking like a penicillin drug desensitization. Seems like you wouldn't do that. You would get them up to that, and you would stay on that dose. But this works differently. It's and I'll kind of go over that. It's not IgE mediated. It's pseudo-allergy. So you're sort of putting them in this refractory period. Apparently, if someone has had 325 on one day, no one has ever reacted to 650 ever. And so it's part of the protocol is that they take 650. And I think I saw someone, I think it was Europe, 3,000 patients, and then Dr. Simon's his large volume of patients that he's done over the years that no one's reacted. He mentioned that. So aspirin exacerbated respiratory disease, that's kind of the newer name, as Dr. Simon mentioned on his Kohler lecture, because it's a little bit more specific to the actual disease. There's also known as aspirin sensitivity, aspirin intolerance, aspirin-sensitive asthma, aspirin-induced asthma, and then in 1968, a study from, I think it was in JAMA, Samter and Beers, and they described this triad of aspirin sensitivity, asthma, nasal polyp. But there's also sometimes you might see a quadrant described as basically they just add sinusitis. So refers to that combination of this chronic rhinosinusitis with nasal polyps, asthma, and a reaction to aspirin and other cyclooxygenase 1 inhibiting NSAIDs. So once again, this is a aspirin pseudo-allergy, so it's not IgE mediated. So the classic symptoms that you get, having at least one or more of rhinorrhea, nasal congestion, less commonly, but you can have some periorbital edema, conjunctival injection, and of course bronchospasm, and rarely laryngeal edema, hence needing the racemic epi and epi on hand. But you can have extra respiratory tract symptoms. They are more rare, but such as flushing, abdominal pain, diarrhea, hypertension. So that's why the code card stuff is needed. So how this works, as with most things, not fully understood, but there's an overproduction of leukotrienes in these patients as well as the leukotriene receptors. They have low levels of lipoxins, which are anti-inflammatory, as well as low levels of PGE2, which is considered the brake on leukotrienes and PGE2. In other words, it's lipoxins and PGE2 are actually anti-inflammatory. And the receptor for PGE2 is also reduced in these patients. So just to refresh your memory, the arachidonic acid pathway, the main two arms are the sort of the prostaglandin pathway. Here's cyclooxygenase 1, so here's where aspirin acts, and then the leukotriene pathway. Xyluten acts on this 5-lipoxygenases, and monoleucas and zafirleucas acts on the cis-acyl leukotriene receptors here. And this is just another fiction here. So how it usually presents, or the clinical history, average age is 35, and it's usually diagnosed somewhere in the 30s. There's a slight predominance for female, and about 40% have allergic rhinitis. So most actually don't have allergic rhinitis. And I think there is a study that's around, there's two of them, one's 36 and one was like 63% of patients had at least one skin prick test positive to an aeroallergen. Many of the patients will have passive cigarette smoke exposure as a child, and how that relates, I'm not quite sure, but that is something they've noticed. Many times they'll say that it seems like it started with a cold, or they'll say they maybe had a flu and they had this watery rhinorrhea, nasal congestion, and sneezing, and it just seems to persist or becomes worse and becomes perennial. And then it becomes more difficult to treat. It becomes more of a chronic rhinosinusitis. They can't smell as well, and then they develop these nasal polyps. And then usually asthma is diagnosed 2 to 3 years later. It's rarely comes first. And then around that same time, they may notice that if they took an NSAID, 30 minutes to 3 hours later, that they have the asthma attack. But many times, at least initially, they actually don't, because they've already had asthma. They already know what an asthma flare is like, and they've previously been taking NSAIDs and never had a reaction, so they don't really make the connection. But the classic adverse reaction, again, bronchospasm, rhinorrhea, nasal congestion, some sneezing, maybe some itching, and then less, and then also some ocular injection or tearing, and less commonly periorbital swelling. And as I mentioned, may not recognize the association initially. One of the reasons for calling it AERD rather than aspirin-induced asthma is because they have underlying asthma. It's made worse with aspirin. So whether they take aspirin or not, as the asthma runs a protracted course, and it usually becomes quite severe. And there was a study in 2000 in Europe that showed about half of them required chronic systemic steroids at a dose of 8 milligrams of prednisone per day. Even though their asthma is terrible, they find that the nasal congestion, or some patients, or many of them find that it's more troubling than the asthma. Many patients have elevated eosinophils, and I mentioned that study that about 34 to 64% have at least one air allergen on a skin prick test. They usually have about 5 to 6 sinus infections per year, and when you see them, they usually have already had around 3 sinus surgeries already. And characteristically, the polyps, when they cut them out, they rapidly regrow. Yeah.
Is there any evidence to say that if they stop taking NSAIDs, the polyps stop occurring, or is it just like an initial thing when polyps start?
Yeah, it's like an initial thing. So it's the same thing with the asthma. It's severe, and it doesn't. It's not like if they stay away from NSAIDs that it'll get better.
So it just keeps going. Okay.
Yeah.
There's more evidence it's not an allergy per se.
Yeah.
Where you would avoid it, your treatment would be avoidance. So this
Right.
doesn't make any difference.
Right.
Okay.
So how do you diagnose it? It's mainly clinical if the triad exists, but depending upon the time when you see the patient, they actually may just have the rhinosinusitis and nasal polyposis, so that makes the diagnosis a little bit difficult at that point. And then rarely they begin with the asthma before the sinusitis and nasal polyposis. So technically, I guess you could desensitize them without having asthma, and if they just had the rhinosinusitis with nasal polyps. I'll minimize that. So you ask about any use of NSAIDs after they had the first recognized reaction, but aspirin challenge is the only way to actually definitively diagnose it. But you usually, it's not the same kind of challenges as you would with, say, with antibiotics, because you're challenging to prove that they're not allergic to it. But this is different. The challenge and desensitization sort of go hand in hand. In other words, you don't challenge them unless there's a specific need for the NSAID therapy. In other words, if it's for treatment of AERD, or if they have AERD and, say, cardiovascular disease, and so they may need chronic daily aspirin, whether it's 81 milligrams, or sometimes the cardiologist may want 325 daily, because if they have an acute MI, they would need 325. And then if they have rheumatologic disease, they need NSAIDs for pain. So how do you manage? Well, basically the asthma guideline, or the asthma is managed according to the guidelines, but you put a little bit more emphasis on giving a leukotriene antagonist, a receptor antagonist, or the Silute also be used. So the therapy, topical steroids. Many times it will require oral corticosteroids plus or minus antibiotics for sinus infections. And then if they have concomitant allergic rhinosinusitis, treating with antihistamines like you would, and as well as immunotherapy. You can avoid NSAIDs, and that's specifically mainly to the cyclooxygenase 1 inhibitors. But there are some that are considered relatively safe. For example, acetaminophen is not usually considered an NSAID, but it does have in higher concentrations. It does inhibit the cyclooxygenase 1 at the higher doses. So 20% actually react at a dose of 1,000 milligrams, but it's considered that 650 is safe. Salsylate is considered safe, as well as celecoxib. The other two COX-2 inhibitors are no longer on the market. And meloxicam, that one is a little less, or more patients will react to meloxicam than the other three, because it does inhibit the cyclooxygenase 1 a little bit more than the others do. And then, of course, aspirin desensitization. So the whole or with desensitization, if someone has an acute reaction from the NSAID, they're put in a refractory period for 2 to 5 days, and that occurs whether they inadvertently had aspirin or an NSAID, or you desensitize them. So actually, if someone has AERD and they came to the emergency room for an asthma flare because they had aspirin, actually for the next 2 days they could take aspirin and not have a reaction. So the idea is basically to with the aspirin desensitization, is to produce a mild controlled reaction, to put them in this refractory period, and then keep them in this refractory period with daily aspirin use. So you want them to have some sort of reaction while they're there, but you want it to be mild, and so you can treat it. And then the first reaction is I don't know, I'm hesitant to say almost, but I thought I said red. It's almost, or it's always the worst. So once whatever happens initially, that's the worst reaction. So the protocols, there's been several, but and so some vary with what pre-medication are needed, and aspirin doses and the timing. But most of them say that requirements, you need to have FEV1 of at least 70%. And that 2007 Annals practice paper says to check it a week prior, then the day of, and every 90 minutes during the procedure. From Dr. Simon's lecture, he likes to definitely use combo or combination LABAs with inhaled corticosteroids, but it seems that usually these patients have severe asthma anyway, and they're already on it. Plus or minus the steroid burst before desensitization to ensure asthma control, and leukotriene plus or minus dilutin. And I think Dr. Simon tries to give both. We would have given both in our patient, but Xylutin under the Truman plan costs $700. So yeah, and without the Truman plan, it's $750. So.
Do a lot of patients achieve control on a combination of those two without it?
I don't know if it's a lot of patients, but I guess the depending upon how comfortable you are with how severe the reaction was, how comfortable the patient is with the risks of doing desensitization, there's all kind of play a factor.
Right. Especially with like side effects of fluid we talked about.
Yeah. So I assume that at least some patients can have controlled asthma, at least to the point that they don't want to go through with aspirin desensitization. But I don't know the percentage. And so you hold antihistamines 48 hours prior, because that will block the nasal and ocular symptoms, and that can sometimes be the first sign. So you'd want to treat that, and then sort of be ready for albuterol. So that's the reasoning for holding those antihistamines. And as mentioned, having code cards, intubation available, the albuterol, racemic epi, IM epi, and then antihistamines immediately available. And of course, having staff that knows how to deal with.
So if there's you hold the antihistamine so that you're better able to get a first sense of when they're reacting.
Yeah.
And then when they're reacting, though, you're going to treat it like asthma. You're going to give them
actually, yeah,
the nasal symptoms.
Actually,
like the early airway.
And that's kind of what I thought, but no.
Oh. Okay.
You can treat their nasal. Say they just have some nasal congestion, treat it with oxymetazoline or but you could also treat it with antihistamines at that time. But I think it's from what I gathered, it's kind of like, okay, go ahead and make sure the nebulizer's fired up,
Okay.
So you said you started wheezing and you gave her breathing treatment. So what's your period that you feel comfortable then
3 hours.
proceeding?
3 hours. So if their symptoms are controlled in 3 hours, you repeat the dose.
So in this person, did you repeat? I don't remember.
No, because so the next slide, when to treat. The practice parameter, or practice paper that I read is if their FEV1 drops 15%, then you go ahead and treat for asthma. But this is from the up-to-date article, I think was from Dr. Simon, and he says if it's just bronchospasm alone, you can wait to 20%. But if you have both nasal ocular reactions and bronchospasm, the bronchospasm is 15% of FEV1. But we just said if it dropped by 15%, we were just going to treat. And then laryngeal spasm, you can treat with racemic epi or IM epi, depending upon the severity. And then just the rhinitis and conjunctivitis, you can let's see, where is it? Well, you can treat with antihistamines or, like I said, the oxymetazole.
So the systemic response to the flushing, urticaria, hypotension, you give epi.
Yeah, right.
You wouldn't think the antihistamines would work with this kind of thing, right? If it's not an IgE mast cell degranulation.
Yeah, you wouldn't think so. But I think mast cells are involved with because mast cells are involved with leukotrienes and prostaglandins, but yeah, it doesn't seem to completely add up, but it helps. It's kind of small to see here. A lot of the previous papers with checking for or trying to figure out what doses to give, or a protocol, you'll see that they gave like 10 milligrams of aspirin, or 30 milligrams, or 60 milligrams. But with an 81 milligram tablet, it's easy just to cut it in half. And so basically, we're just looking at this guy here. These are different types of reactions, but the AERD sort of picture. Start at half an aspirin and then just double every 3 hours. And I think Dr. Simon did mention that he felt that 2 hours, waiting 2 hours could be okay, but they always wait 3 hours. But actually, in our patient, we just waited 2 hours between the first and second dose, because most of the reactions are between 60 and 100 milligrams, or i.e. 81 milligrams. So not very many people reacted at 40.5, so we just went ahead and gave 81, and then waited 3 hours, gave this dose, waited 3 hours. The next day they come in, you give the 325, wait 3 hours, everything's okay, you can go home. And actually, you can just go ahead and give 650 the next morning. We gave 325 again at home that evening, I guess just to be double sure she's in sort of refractory period, but it's actually not, I don't think that's necessary.
So is that person going to be on 650 PID indefinitely?
Indefinitely?
Or let's say you were talking about desensitizing for coronary artery disease or whatever. So, I mean, they use a lot less dose than...
Right. Well, so 81 milligrams is, the sort of preventative dose for cardiovascular disease or coronary artery disease. But if you have an acute MI, you need 325 right away. So indefinitely, I think so. How high they need to be?
I thought there was something where, I don't remember all this because I don't deal with this very often, but I was thinking that there's like a minimum desensitization dose that over time they can drop down. I thought it was like,
325. Okay. So for AERD, 325. If you're doing it, if they have AERD and they have cardiovascular disease or coronary artery disease, and all they need is 81, and I guess if they had an acute MI, I don't know, because they need 325 then, but say they need, then all you need is 81, so they can't take any more than 81, so they'd be on that 81. But if you're trying to treat the symptoms of AERD, then you need this higher dose. So that's just, I'll mention that. So usually they notice some improvement after about a month of therapy, and then they notice a significant improvement in about 3 to 6 months. So the benefits: reduced nasal congestion. They have surgery about once in every 10 years rather than once every 3 years. They have decreased sinus infections from 6 per year to about 2 per year. Their smell is better. They have increased asthma control with decreased use of systemic steroids, inhaled steroids, and nasal steroid use. And then after desensitization, they can actually take other NSAIDs as long as they're on at least 325 per day. So if they're on that 81, they can't take other NSAIDs. But if they're taking 325 a day, then they can take in other NSAIDs. And I didn't realize this, but they can substitute other NSAIDs without losing tolerance. So say they're on, the 650 of aspirin twice a day. Well, they can take a full dose of ibuprofen in its place and still be without losing tolerance.
I always was told that you can desensitize with aspirin, and if you do, they can take an NDN.
Yeah, they can take whatever. But not only can they take whatever, they can switch from aspirin every day to ibuprofen every day.
What about COX-2?
COX-2, yes, they can take that, but they can take that anyway.
Right, so that's right. Could you do that for a decent?
Oh, no. If you take COX-2, you don't lose.
Okay.
Because it's the you have to have a cyclooxygenase 1 inhibitor.
Are there any COX-2?
Self-oxygenase, yeah. I can use brand names because they're off. Vioxx and Bextra are gone because of the increased cardiovascular risk. So how long do they need to be on that for the AERD symptoms, and what dose? So after about 6 to 12 months, you can try decreasing them to 325 twice a day, and about half will still be at the same level of control, but the other half will have worsening symptoms. So, flip a coin. If you drop them down, two are going to have to go back up to control their symptoms. But then again, you may, if the symptoms are still relatively controlled, the patient is okay with that control, then maybe they could stay at the 325. So how often can you miss the dose? So you can actually miss 2 full days of the 650 BID, and just or 4 doses, and then just go right back on it and not have any problems. But if they miss 3 to 5 days, then the usual recommendation is come into the office and take a 325 and kind of sit around for about 3 hours to make sure everything's okay. If everything's okay, you can go back up to 650. But if it's more than 5 days, you're going to have to start all over. But the good thing is that resensitization is gradual. So if you miss 3 days and you have a reaction that's going to be more of a mild reaction, if you miss 4 days, it's going to be a little bit more. 5 days, it's going to be more. So it's not, it's not the same as like an IgE reaction. Side effects. That study that Dr. Simon showed us, I think it was about 30% of those that discontinued treatment did it because of gastric pain and irritation. So, and this didn't really seem to be that much improved with H2 blockers or proton pump inhibitors. And so this is the most common reason for discontinuation. So the first thing you kind of think of is the incidence of gastric bleed, but in that study, it's the same as what it is for someone who is on 81 chronically. So, or at least the percentage was the same in that study is if someone is on 81. So therefore, the risk is not increased. And basically, that's all I've got. So if there's any questions or comments or concerns.
Do you know how long that study was done that watched for gastric bleed?
Yeah, I think it was let me, I got it right here. I think it's about a year.
Seems like over 1,000 milligrams per day.
Yeah, I saw, don't quote me on that year thing. I can't tell you for sure.
If you have AERD and there's no expectation that patients ever going to need an NSAID, like they could just avoid NSAIDs if they wanted to.
Right.
Yeah. Ever desensitize them?
Yes. Well, they're asthma, then they're terrible control, and that would be a reason why.
So you would improve their asthma even if they're not taking NSAIDs by desensitizing.
Yes. Yeah. You improve their asthma, you improve their nasal congestion, you decrease their sinusitis, and you decrease the number of surgeries.
So is it all like that pathway's kind of revved up already? So
yeah. Well, it's sort of because the lipoxins and this PGE2, these are anti-inflammatory. So if everything is working right, it's kind of thought this is kind of it's checks and balance, So it's sort of regulated. But if these are out of whack, you have increased LTC4 synthase, you have increased number of leukotriene receptors, increased number of leukotrienes, and you're sort of out of whack. And so if you immediately block this side, I think, at least the way I think of it, I don't know if it's entirely true, it's sort of like you block this all of a sudden and it sort of shifts it this way. I don't really know if that's true. That's the way I think of it.
So even if you don't anticipate them having exposure to NSAIDs, virtually almost all these patients still benefit from desensitization.
Virtually, if not all.
Looking at the pathway, you usually think that dilutin, you just have a preference of using dilutin without using any of the other leukotriene antagonists. And I wouldn't know what the purpose of being on montelukast and dilutin if you use dilutin, you're blocking the pathway to begin with.
Yeah, and so when we looked back last night at the COLA lecture by Dr. Simon, and so when it first came out, he was kind of saying that it looked like it was kind of a straight drug, and for whatever reason, just doesn't seem to control it quite as well. But the same thing with the montelukast. If they have 5 to 10 times as many systemic receptors, you're not blocking every one of them with montelukast either. So that's sort of a reason for kind of using both.
Because dilutin, when it first came out, it basically lost its market share because it was 4 times a day initially. Now they have it twice a day. But also there was a high risk of, or it seemed to be, or whatever, there was concern about liver problems. And initially we had to check it, baseline and every month for like 3 months, and if it's fine, then you do it every 6 months, and so this whole process.
Right.
So it got to the point where people didn't want to do that.
Right.
Yeah,
and that's the downside of it.
Has that changed? Since I haven't prescribed it in 15 years.
As far as I think what most people do with current recommendation is check it in a month, 3 months and 6 months, then yearly, or 6 months yearly after that.
I don't remember the dosing, but it seemed like that dose was a high dose.
I think it's like 1,200 milligrams twice a day. It's CR
yeah, I just don't remember that. I don't remember it being that high. It's in milligrams.
Once they're desensitized, you can stop the anti-leukotrienes.
No, you continue them.
Okay.
You continue the leukotriene receptor antagonists as well as the your asthma treatment. So you can back down on your if your asthma becomes better controlled just like you would normally, but I think you preferentially keep the montelukast or something.
Okay. It doesn't really make sense, like the whole idea of desensitizing, because you're still providing aspirin, so you're still going to block constantly.
Yeah, I know. And I'm thinking that maybe it's kind of like when you're sort of like a controlled release of, say, all these leukotrienes from the leukocytes, and so you sort of deplete it. You want to deplete it slowly. I mean, this is just what I'm thinking in my mind, rather than getting all at once and then you have the reaction. So if it's sort of depleted, you're chronically giving it, it can't all of a sudden get this one big burst. But I don't know. That's kind of the sort of rationalized it in my mind.
If you can get by with just montelukast, that would be preferable.
Yeah, Yeah,
side
I mean,
effects?
so I mean, if their asthma is well controlled,
Yeah.
but usually that's not what happens. It becomes more severe.
So is the dosing of that the same as like for adult 10 milligrams?
Yeah, it's 10 milligrams.
So you wouldn't think there'd be benefit of putting like 10 twice a day or something like that?
The only thing I saw was that if someone wasn't on montelukast and they're getting desensitized, I think Dr. Simon says you can do, I think, 20 milligrams the day prior, and then 10 milligrams for the days that they're on it. And that's the only time I saw an increased dose, but I just saw the 10 milligrams daily.
Anybody else in the audience have any questions? If not, we'll end the talk for today. Thank you, Dr. Johnson, for your conference, and we'll see you all Monday for immunology. Have a good weekend.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.